Fantastic talk, Dr. Chopra. There's going to be a lot of questions about this, I'm sure, when we get to the panel. So next we're going to go with Dr. Alex Yelenskiy, who's going to speak to us a little bit about glaucoma lasers.
So my name is Alex Yelenskiy. I'm a glaucoma fellow here at Doheny, and today my talk is going to be on laser glaucoma treatment. What's new? I have no financial disclosures. So some of the main topics of the presentation, I'm going to discuss the safety of micropulse, as well as which groups of patients may benefit. I'm going to discuss the settings used for micropulse, and I'm going to discuss the issue of mydriasis. And the two main studies that I'll cover is the study ongoing here at Doheny and the study that I did at Tulane. Just a quick overview of laser glaucoma treatment. We have argon laser trabeculoplasty, started around late 1970s, peaks at 488 and 514 nanometers. And the issue with that is there was a lot of tissue damage and coagulative necrosis. Then we have the SLT, less tissue damage, started around the mid-90s with Latina and Park. Then we have excimer laser trabeculostomy, described early on by Berlin, and that's at 308 nanometers, and it uses a xenon chloride laser. And then the interesting thing about the trabeculostomy is that it's a photoablative process. It removes the TM and inner wall of Schlemm's canal. It's not approved here in the U.S., but it is approved in Europe. And there's an interesting mechanism where they describe a pneumatic canaloplasty, where the bubbles essentially cause a canal dilation during and after the procedure. Then we have the micropulse trabeculoplasty that's being used with the use of the micropulse diode laser, and that was initially described in 2005. And then we have the continuous wave and the newer micropulse cyclophotocoagulation, and the ECP is an endoscopic approach, and it uses a very similar laser energy as the micropulse, as the continuous wave. Just a little bit about the excimer laser trabeculostomy. As I described earlier, it creates microperforations in the TM, and it's an ab interno approach done during surgery. Uses xenon chloride excimer laser, and it actually many studies show very similar efficacy as the SLT. Some studies show a 53% success rate, and 40 in SLT. It's approved in Europe and not in the U.S., and there's an interesting mechanism of the pneumatic canaloplasty from the bubble formation of the excimer laser. And then a little bit about the micropulse trabeculoplasty. The good part is that it functions similar to SLT, and it doesn't cause significant damage to the TM, so it's possible to do further ab interno procedures after this laser. And the MLT and SLT show very similar efficacy, and some studies do show a possibly increased failure rate of MLT. Just a quick blurb about cycloablative procedures, since we're talking about the micropulse cyclophotocoagulation. Initially, cyclodiathermy started in the 1930s, and these initial procedures had significant tissue damage, so there have been developments over the years to cause less and less tissue destruction. Cyclocryotherapy was in the 1950s. That was, of course, for refractory glaucoma. Briefly, they experimented with high-intensity ultrasound, but the issue with that was that there was significant scleral ectasia. The first more modern CPC was in the 1970s with a ruby laser, followed by YAG laser in 1973. Then in the early 1980s, the diode laser began to be used, and the first clinical use of that was in the early 1990s. And then along with that, they developed a similar endoscopic approach for CPC in 1992. And there have been attempts to use a transpupillary CPC, but that's limited by the pupil dilation. So the diode laser has been used more and more because of its cost, efficiency, and portability. The traditional diode CPC is 810 nanometer laser. It's it's absorbed by the melanin in the pigmented ciliary epithelium, and it's some studies have shown that it's more effective in the operating room, which is why it's well, partly for pain control, and I think there's more control in the operating room, but. And then the micropulse CPC is a newer form of the diode laser. It uses the same wavelength, it's less energy because the pulses are interrupted. So we have the micropulse diode laser. It's less energy, less collateral tissue damage because it's not always on. It has an on and off time. It's some people think that it causes increased uveoscleral outflow. There's actually a paper that came out recently. Actually, it was a poster presentation at AGS that shows that it might function in a pilocarpine type effect, where it affects the muscles of the ciliary body and causes contraction, affecting the scleral spur and opening up the TM. And due to the decreased collateral damage, it can micropulse CPC is used as an earlier treatment option, not just for end-stage glaucoma. Just a quick overview of the literature. Some of the first papers that were published were in 2010 in Singapore. Mean follow-up time was 17 months initially, and showed an 80% success rate. And there were a few complications, but they did have some hyphema with NVG patients, mild AC reaction. Then in 2015, they compared micropulse and continuous wave CPC. And they experimented that in end-stage patients, 48 patients, and that was again in Singapore. And what they found was that micropulse has reduced IOP variability, and they actually had a 75% success rate in micropulse versus 29 in continuous wave. And then in 2016, they experimented with advanced glaucoma. It was a retrospective study with Weisberg and colleagues, and it was only 19 patients and 60 days follow-up, and there was an 89% success rate. One case of hypotony and one case of corneal edema. Now, as you note, that most of these studies didn't note any issues of mydriasis. And then in 2017, the Glaucoma Associates in Texas with Emmanuel Grover and Fellman, they came out with a study with a mean follow-up of 4 months, although 84 eyes and retrospective, and they followed them for 1 month, and it was a 40% IOP reduction. Then in 2017, they compared adult versus pediatric patients at UCSF with Shan Lin, and they found that in pediatric patients, micropulse was minimally effective. It was much more effective in adult patients. An interesting study in 2018 in Romania came out. They looked at choroidal thickness after micropulse, and they found that patients that had where micropulse worked well, the choroidal thickness increased, and it was statistically significant. And their theory is that maybe that supports uveoscleral outflow theory. Just a couple more articles that recently came out. There is a retrospective study at Wills that came out recently, and they looked at 79 eyes. And they actually had quite a few, in that study they did show quite a few complications. They had 7 hypotony, 21 prolonged AC reaction, some macular edema, 2 phthisis, and 2 corneal edema in that study. So one of the issues with micropulse, since it's new, there's some standardized parameters that most people use for the settings, but the optimal setting has not been standardized, and I think that's very important for various stages of glaucoma and to minimize side effects. And with this study, in 2018 in Argentina, they did a meta-analysis of all the available literature, and they looked at, they converted the power into joules. So they multiplied the seconds and then times the watts, and then they got joules. And they figured that based on this chart, there is kind of a exponential increase in complications once you pass the 180 seconds to 240 second mark. But there still needs to be a lot more studies to look at the exact optimal parameters for micropulse. I think right now, it's standardized at 2,000 milliwatts and essentially 90 to 120 seconds per hemi. So as I mentioned earlier, what is the mechanism of micropulse? It's still not known, but it can be a combination of mechanisms. It may increase the TM outflow, or it may increase the uveoscleral outflow. It can potentially act on the scleral spur. There was a poster by Johnson, Murray, and AGS 2017. They looked at monkeys, and they thought that one of the potential mechanisms is essentially contraction of the longitudinal ciliary muscle and pulling on the scleral spur and opening the TM, similar to pilocarpine. But it can be a combination. We still haven't figured that out. But since we don't know the mechanism, the goal is to reverse engineer and for now figure out which groups of patients micropulse functions. So there's a study that's ongoing here at Doheny, and we're looking at which groups of patients micropulse functions and whether micropulse is effective. So the hypothesis is that based on previous studies, micropulse is effective with minimal side effects, although it can cause serious side effects in few patients, but not as the previous continuous wave. And also we wanted to look at whether there is an increase, a better efficacy in patients that have had previous glaucoma trabs or tubes, and whether tubes or trabs that are failing, if we can optimize them with micropulse. So the basic parameters of the study, we used, most of the time we used standard settings, but dependent on what type of previous surgeries the patients had, we modified it to avoid any areas of previous incisional sites. So the success parameters were pretty standard. Pressure between 6 to 21 or 20% IOP reduction, and no subsequent glaucoma surgery. As far as the demographics of the patients, average age 66, relatively equal male-female, and the majority of the patients were Caucasian Hispanic. And in the study here at Doheny, most of the patients were open-angle glaucoma. So many of the patients did have previous glaucoma surgery. As you can see, there was essentially 87% of patients that had some type of previous glaucoma surgery. So we had good results here at Doheny. There was a 29% decrease in mean average IOP, and there was a statistically significant decrease of topical medication usage. And as you can see, at each time point, there is a significant decrease in IOP. So at essentially 12 months, there was a 57% probability of success at 12 months. And this is a Kaplan-Meier graph that compares patients with previous glaucoma surgery and no previous glaucoma surgery. And the probability of success was statistically significantly higher for patients that have had previous glaucoma surgery. Mean treatment time was 215 seconds, and we actually compared IOP below 180 seconds and above, and we didn't really find any difference in IOP outcomes based on the treatment time. There was some decrease in visual acuity and hypotony as far as complications. So overall, the laser is effective, and from our studies, we did find that there was no significant side effects compared to the previous continuous wave CPC. And prior glaucoma surgery does have a significant impact on the efficacy. Now I'm just going to go over quickly about with the study at Tulane. So we also looked at the safety and efficacy of micropulse. So we basically gathered multiple sites around the country, most of them former Tulane alumni, and we gathered the data that from the early use of micropulse in their groups. And we looked at all stages of glaucoma. So very similar surgical technique, a very similar procedural technique. It was done in the operating room most of the time, avoiding the 3 and 9 o'clock positions, and a similar surgical success rate. Similar surgical success parameters. Demographics, we had 197 eyes, mean age 73 years. Majority were Caucasian and African American, and the major glaucoma subgroup was open-angle glaucoma. So we had a median follow-up of 12 months. There was a 26% decrease in mean IOP compared to 29% here at Doheny. And we had a statistically significant decrease in topical medication. And this is just the graph that shows that at each time point there was a significant decrease in mean IOP starting at day 1. The overall success rate was 71%, and we also found that patients with previous incisional glaucoma surgery showed that MicroPulse was more effective in those patients. And this is a Kaplan-Meier graph that shows that at 90%, at essentially 12 months, 90% of patients were free from repeat MicroPulse. As far as complications at the Tulane study, majority of patients did have some pain during the procedure, and really the most significant complication was CME, which actually resolved with treatment. As far as closing remarks, both of these studies and studies in the literature have showed that MicroPulse is an effective procedure, and it can be used in patients that have had previous incisional surgery, which it may work better in those patients, and possibly avoiding incisional surgery in the near term. The other issue is that in the literature, mydriasis is an understated, it shows understated occurrence in the literature. There was a paper with Shanlin at UCSF where they looked at mydriasis post-procedure in MicroPulse, and they found the majority of patients did have an issue with mydriasis, but it resolved by 3 months. However, in most of the literature, mydriasis isn't noted, and it's probably a documentation issue, and unless patients complain, I'm assuming that wouldn't be documented a lot of the time. And these are my references.
Thank you, Dr. Yelenskiy.